I'm super happy to see you again, Richard. As always, it is a pleasure. We're having these fantastic conversations that just keep on growing. It's the conversation that keeps on giving. Yeah. Think big, act now. And today we have Sally Banister, who is the Deputy Director of Service Delivery at Dorset CCG. Yeah. Wow.
Looking forward to her. She's a bundle of energy, which is just great. You'll see that, I think, as soon as we start talking to her. But she's a practical woman as well. That job, service delivery, she'll tell us, I know what that actually means. But she's so practical and yet also challenging what's possible, what's feasible. And I think I'm really looking forward to this one.
Absolutely. Absolutely. Let's go. Excellent. So in terms of how we want to frame the discussion.
Right.
I see Richard is warming up his hands. There's lots of exciting stuff that we want to touch base with you, but essentially we want to get across the think big, act now. And I think one of the core elements you mentioned just prior was resilience as maybe one of the components that we need to have, it's like a clog of armor around us as we think big and act now, because sometimes people will throw stones at you. Or if you stick your head above the parapet high enough,
I've just come off a call like that.
Have you? Can you tell us what the call was like?
Well, it was about our programme that's called Think Big, coincidentally.
Okay.
So that's confused a lot of people looking in my diary. But so our local programme called Think Big, which is a little bit more radical and has a bit more risk appetite than things traditionally do in the NHS. And it's been probably to date, it's been a relatively closed group of enthusiastic people that want to try something different. And it's not foundationless. It does have a basis. So we know, places like one of our work streams is around ophthalmology. We know Moorfields has done it like this before. And one of our work streams is around breast screening, and we know somewhere else has done it like this before. But as soon as you start opening it up, you meet the people who are more traditional in their approach and start to tell you all the reasons why you can't do it. And that's fine. And those are hurdles that have to be overcome. Like, it is really important that there's no asbestos and we have radiological protection for the people that are using the breast screening unit. And none of us would have thought differently. But let's start from a position of where we might be able to do it, not from a position where we can't, and then let's work from there. So I mean, I can just talk, you can just set me going and I'll just talk. So you have to stop me if you want me to. But I've been really amazed by how resilient people have been. So if I think about people in my team last, let's think March, when people got sent home, if I'd have predicted who was going to manage well and who wasn't going to manage well, and how much people would get done, I wouldn't have been as optimistic as I should have been, because people have been amazing. People who I thought had limited sort of resilience have absolutely turned their hands to something they've never done before, picked it up with gusto and applied brains and creativity and ingenuity to things that I just didn't think they would.
Oh, and why do you think they've done that, Sally? Or how have they done that? Why have they done it? I don't know.
Yeah, I think the common enemy of fighting the pandemic has brought people together where they were in sort of slightly opposing teams or competitive teams before. That's one aspect of it. But I think it's the right, I'll just roll up my sleeves and I trust that the organisation around me isn't going to condemn me if I get it wrong, but that the thing that we've got to do is so big, let's just crack on and have a go. And I think that has prevailed and has taken over from, I must write a paper and get it through 3 committees before we can even slightly tweak something. People have been a bit more fluid and they felt permitted to be more fluid.
Yeah.
And that's the bit I want to keep.
Excellent. Yeah. So in your role, then if you just give us a brief description of what you do in your role, and also how would you measure success in your role when you're working in such a dynamic environment?
So my title is Deputy Director for Integrated Care Development, which could mean almost anything, which I like. And I'm responsible for elective commissioning, maternity. I have a dotted line to all the cancer commissioning. So I look after all the staff, but they work to an integrated, a mini ICS, but I look after the team. I'm responsible for the CCG's contract monitoring and relationship management function and system-wide performance reporting. So amongst all of that, I can get myself involved in almost anything that isn't primary care or community services or mental health. In terms of success, I think, so there'd be some things, you know, I'm sure the CCG would want me to say, like a well-managed contracting process and no surprises for the governing body and those kind of things. But actually what I want is to run the team everybody wants to work in because it's really good fun and exciting and we're able to offer good value to the trusts. More and more, I think what we do really should be sitting in a trust. It's tactical commissioning, it's not strategic commissioning. So if the Chief Operating Officer thinks my team are delivering a good service to him in terms of supporting some transformation or some QI, then I think I've done a good job. There's a sort of more formal response, which would be, you know, if waiting times return to their pre-pandemic or better levels, those kinds of things. But actually, those are sort of transactional outcomes. What I want is to be managing a set of people that are helping create better outcomes for the health of people in Dorset. You know, actually tangible, what have we changed for the better? That's what I'm after.
And over the last year then, how's that manifested itself? What's you seen that team have brought about? What sort of things have happened that have really cheered you?
So a couple of things around networks where it had felt like we were pushing against a wedged shut door for getting networks up and running, networks of clinicians to share scarce resource across a geographically wide area that's got, you know, a big rural area and a town area. So getting those networks up and running and actually moving staff or patients between places in order to even out access. So you're getting, it's not completely equal, but a more equal level of access, irrespective of whether you live in the place where they happen to have 5 consultant neurologists versus an area where there's only 1. So that evening out of resources, which is part of what we call One Acute Network. So that was one of our STP programs, One Acute Network. So that's one bit that's really, I think, come on a long way in the pandemic in areas where they hadn't wanted particularly to work together previously. And the other is digital solutions. So pre-pandemic, one of my teams was looking after outpatient transformation, and it really felt like we were not getting into the trust. So you had a couple of key people that had come to the meetings and say good things, but nobody was that interested in doing the developments. Whereas now, or pretty much from as soon as the pandemic hit, people's interest in those digital solutions shot right up, and so did the use. So we, at the beginning of the pandemic, we had very small use of virtual consultations, and we now regularly have 600 virtual consultations a week, which is about 250 hours worth of consultations a week. And that's been because clinicians found it necessary during the height of the pandemic, but the benefit of it they've seen carry on even when the pandemic's receded slightly. So they're still interested and still doing those consultations online, even though that doesn't save them really much time. Some argue that it might save them a little bit, but it doesn't really save them that much time. But it's hugely more convenient for patients if it's clinically suitable. And, you know, as somebody that recently had to park in Pool's multi-storey car park, you know, it saves you parking fees and stress and congestion and carbon footprint and all of those things. So that's really good. So go on, Richard, what are you going to say?
I was going to say, so one of the things that strikes me in this conversation is that you almost make things very tangible and grounded. You know, you've dissed in a way some of the NHS speak, but equally you go the other way and you just go, no, this is what we've got to deliver. These are the numbers. This is the practical thing. It's not parking. I don't want people parking in Pool car park. And you make it very grounded and real, if I may say. Is that part of this, you reckon?
I suppose so, but we're all patients. We're all patients. So I have had online consultations, and, you know, I live 27 miles from my nearest hospital. So it's pretty much an hour by the time you've parked. It's so much better for me. And I know what it's like. I'm a carer for my 86-year-old mother-in-law. I know what it's like trying to get her into a disabled access taxi. If we could do something in her flat, if we could do something in our local community hospital, that's so much better for her, and it's better for me. And if it doesn't have an adverse clinical impact, well, why not? So let's do it. Yeah, I do really care about these things, but I think I would slightly. I wouldn't want to give the impression that I'm saying to the system, this is what we need to do. That's not, I don't really feel that's my job. My job is to sort of hear and give options to them and then help the system develop what the system thinks it needs to do, rather than act as a traditional commissioner and say, NHS England says there is this policy you must implement. I don't know who's going to be listening to this, but I don't really much care that NHS England says we have to implement policy. What I care about is what's better for the Dorset patient or the Dorset clinician.
And that's a breath of fresh air. That's the breath of fresh air.
Most people.
Yeah,
I think most people would think that.
Do you know what? I think more importantly, to support Richard's point of view, there is you create an environment that enables people to create and introduce better solutions for the health service. And there is this argument whereby you have the protocols, procedures, and all of those things in statute that you have to abide by. But the human side of this, first and foremost, you have to create a safe place where people are happy to come to work, are able to give their all. We've had this compelling event that has changed the whole dynamic, COVID. Now, if you remove that compelling event, there's a risk that people will go back to old ways and put up barriers and all of these protocols, which we do not want. So your approach is one that is refreshing and should be adopted. What are you doing to ensure that all the great innovation that's come through, such as video consultations that have increased, continue post-pandemic?
So I think I would say that Dorset was quite collaborative and progressive even before the pandemic, and even probably going back 3, 4, 5, 6 years, it has been a place that almost through stealth has been gradually bringing I don't know, minimizing the gap between the provider and the commissioner and gradually bringing people, teams together. So I don't think it's just a pandemic, and it's definitely not just me. It is a whole kind of sea of people who whose attitude, it's something you said a minute ago, I think, is about setting the conditions to allow people to be innovative. So Dorset did away with the purchase of provider split quite a long time before you were really given permission to do that. It was already operating combined committee structures between providers and commissioner before really we were given the nudge in the direction of being an ICS, before ICS was a phrase. So we've been doing that kind of thing for a long time. I think the way in which we sustain it is that there's probably loads of different things that we have to do, but one of them is to really share out the good practice, but also share out who leads. So it's not the commissioner defining what's next. It's a shared responsibility across all of us, and we share leading those things. So within elective care, We've got a number of programmes underneath our elected care board, and some of them are led by providers, some of them are led by commissioners, some of them are led by GPs. They've all got everyone in them, but the responsibility and the sort of distributed leadership helps us knit everybody in, I think, for the long term. I mostly think the things that we are involved in sit best in a provider space. And so whilst my team are helping, they're helping. They can't drive it on their own. It's got to be out in the provider world. And the commissioner's role is probably going to shrink to be more about strategic commissioning. I think having people in place who are prepared to take a bit of a risk rather than more traditional commissioners or even more traditional NHS managers, probably having a bit more of a risk appetite, will support keeping the things that we've gained. So the other digital things we did our digital library using HCI, which when we started pre-pandemic, we were looking at, let's do 2 or 3. Let's start small and grow it and get some kind of momentum behind it. And actually, with Richard's help, we went really big, and we went for 300 very, very quickly, and we're now at, I think, 400 and something. And I think people's appetite for being able to help their patients, knowing that they couldn't help them face to face as much as they wanted to do, help them get on board with the idea of something else that they might have balked at otherwise.
And Sally, just looking ahead, your think big. Could you just, because getting down to the tangible, I'm conscious of time running away from us, but could you just describe what you're doing in your think big and let us know? Because I think lifts what you've seen and makes it a future looking program.
So what we're trying to do is look at our massive backlog of patients, and that's not just patients waiting for a first appointment. Sometimes it's for follow-up or screening. What can we do how can we narrow that down through digital validation? How can we, in a really personal way, ask people questions and then take the information from those questions and work out what is the best route for those patients? And then when we've narrowed that down to the people that we must see, then how many of them and how can we see them virtually? And then when we've narrowed that down and we've got the ones that need to be seen face to face, how can we ramp up by an order of magnitude our ability to see patients face to face? And the way we think we're going to do that is by running outpatients like the mass vaccination centres in a big open plan space, so potentially a shopping centre, using a kind of lane structure. And we might swap one specialty in one day and swap another one in another day, use volunteers, have it connected to lifestyle stroke type choices. So if we're having an orthopaedic lane, we might see people who've been on the waiting list for an orthopaedic surgical intervention. And actually what we might find is a more conservative approach or a lifestyle approach might help them now and mean they don't need the operation, or help them in the meantime whilst they wait. So looking at things like Healthy Dorset, Active Dorset, those kinds of third sector organisations that we might be able to have on the premises. And then at the very back end, for the people who absolutely do need a surgical intervention, making really good use of the independent sector at a scale that perhaps we haven't done before because we haven't needed to before. So there's a lot of learning from the vaccine sites. We've got somebody in my team that was involved in our local mass vax centre, but also was the military person in charge of the First Nightingale, the build. Yes, so he is advising us on the build within this large open plan department store in a shopping centre. And there are lots of benefits to that. So it's right next to the bus station, the train station. The shopping centre will love it because they'll have footfall, and they are absolutely decimated. So there are loads of things. There are lots of barriers to overcome, like, is there asbestos in the roof? What's the radiological screening going to be for the breast screening equipment? But these things are doable. I think the pandemic has shown us that lots of things are actually doable if we have some urgency and pace behind it.
But also leadership that's brave, if I may say. Because actually I don't know how you write a business case for that, or whether you just go, no, we believe.
So that is what I'm struggling with right this week, because I need to put something in that gives the trust that is predominantly leading this. And I would say this is being led by one of the coups, not by me, but he needs the confidence to write the checks. So the system needs to give him the confidence to write the checks. And it is a little bit on faith. And actually my boss has said, don't write a business case. Just keep taking people with you on the story. And I'm, whilst to some people they think I'm a bit flaky and a bit wacky, to other people I'm like the forces of conservatism, because I'm saying, no, I think we must have a business case. So somewhere in between, you have to have reasonable governance. It's public money. On the other hand, we don't want to be tied up so much in red tape that we don't get anywhere, because there's no good governance or privacy or dignity in being sat untreated on a waiting list. And our responsibility is to treat those people, not to do the safe thing all the time that's easy, which is sort of nothing, really.
Sally, you're a very inspirational leader. And leadership is what Richard was speaking about earlier. And I just want to paraphrase what I'm getting from this. It's radical. You have to be radical as an organization and the people within it. You have to think in very radical ways. You're taking learnings from a pandemic and reframing them to introduce new capabilities into the health system. We spend a lot of time talking about our hospitals needs to provide care outside the physical boundaries of the hospital. That's exactly what you're doing. And the challenge you have, and you articulated it well in terms of the benefits as you see it. With innovation, we always know there's going to be new, unquantifiable benefits to anything you innovate, because you don't know until you brought in the new capabilities that you have. Do you
and
find
actually,
that
we talk about this, we are talking about it often as an experiment.
Yeah.
Because we don't know what challenges will come up against, and we also don't know what things we'll learn from it, but we know there'll be things that we'll want to build into how we do outpatients in the long run from this. Rather than it just being a 12 to 18 month standalone backlog clearance. There'll be parts of it that are like that, but there'll be other parts of it that we want to keep as a kind of legacy for how we deliver outpatients for the next 20 years.
Sally, we're out of time. I could talk to you forever, I've got to say. If there was one thing you'd say for people going away from this call, this discussion, what would you say they should get on and do, or how should they think, or what's the one thing that would stick with you that you'd like others to think through?
I think it is about being brave enough to step outside of what's safe and traditional. And not all of those things will work, but some of them will, and then we'll learn from it, because none of us learn from doing the same thing as we did last time. You know, it's safe and it might achieve X, but it's only going to achieve X. But if we want to achieve X and Y and Z, we need to try something else. So being brave enough to try.
Excellent. And I'll take another message in terms of the story, taking people on that journey with your story. This is now the second show we've done, Think Big, Act Now. And there's a theme emerging here, Richard, and that is about resilience. It has come up, and being brave. You know, something about bravery is coming up there. So, no, thank you for that. There's the synergy there, and we're inspired. Think Big, Act Now. Your name should be a verb, because you're a doing person.
To Sally. That's what I say. To Sally.
It's not just, it isn't definitely not just me. So.
No, thank you very much for your time. It's much appreciated.
Thank you.
Sally, you're a star. Thank you so much. Everybody will benefit from this. Thank you, and see you soon. Thanks again, Sally.
Cheers. Bye-bye.
Bye-bye.
Take care. Hey.
Hey, Douglas. Good afternoon, sir. How are you?
I'm doing great, thank you. I'm doing great. Reliving that conversation with Sally Banister was enthralling. I really loved it.
Yeah, she was superb, wasn't she?
Yeah.
Absolutely brilliant.
Absolutely.
I'm not sure where she is right now. I'm going to see if I get a message. No Sally at the moment. So it's going to be me and you, I'm afraid.
Wow. Wow.
So we're going to try and cover for her, but maybe what we could do for everyone, we've only got a few minutes anyway, because she was 25 minutes. And
yeah, she packed a lot in there.
Yeah, we could have done a lot, an amazing amount, really. And I think you can see it in the quite brilliant questions that have come through.
Yeah.
Well, I think what they're saying just feeds back on what she was saying, really. So, Georgie, how do other people and organisations in the NHS learn how to act like you? It's so refreshing, and I think it was a learned behaviour, wasn't it? I think from Sally, she wasn't, and she is humble in terms of leadership. She's doing a lot, but she's equally humble. It wasn't me, it's the team. We don't need to do this in the commissioning, the CCG. It can be done at the provider level. You know, that it's not our role. We can just present. We can enable, we can facilitate, we can give them a platform, we can give them permission, but hell, it's over to them and they will make it happen.
Absolutely. And I think that we need to put it out there that every guest that we've had on the Think Big Act Now big conversation is accessible. So George's question is a profound one, but we just want to reaffirm that Sally Banister is available. She's put her thoughts out there. She's demonstrated the value that she's bringing through her unique way of bringing transformation to an organization. So reach out. We've got all the capabilities now on LinkedIn. Connect. Yeah.
Reach with her. Interestingly, I've noticed a number of the speakers have already connected. And I know Adele is speaking to Lisa and Sally, and there's a triangle forming there.
Perfect.
Which is good news. So
absolutely,
really good. So Matt's asked, what did Matt ask? How important is it to give people clarity of purpose to get people on board and delivering? And is that possible in an organisation as big and complex as the NHS?
Yeah, big question. And I'll just say, Sally's approach was about taking people on the journey, you know, on that journey throughout the transformation, opposed to maybe having things top down and just project by project by project. You have to buy people, you have to win the hearts and minds of people and take them along that journey. And as we say that, Sally Banister is right on cue.
Look at that. She just showed she is sallying at the moment, or driving.
I'm not actually moving, and I'm sorry to join you from my car, but I had to come to something, and this was the only way to do it.
That's okay. Did you hear the question that Richard read out from Matt Hall?
About clarity of purpose and giving people that.
Absolutely.
Yeah. How important is it?
I do think it's really important, but it doesn't have to be a single huge purpose. So you talk scale the NHS. You know, there's a single.
Okay.
No, we seem
to have lost Sally there.
And what we know is, Matt, it's important. I know that much. He was adamant about that. So absolute need. And his second half about is it possible in an organisation as big and as complex as the NHS? I think it has to be done, doesn't it? There is no choice. And she's showing it is possible.
That's correct. And the fact of storytelling galvanizes people by the masses. It's one of the first ways we communicate as human beings. So that's transferable across the whole NHS. I think where people struggle is when they do it bit by bit in terms of, and people not understanding where they're going on that journey. You need to talk them through the journey so they can see there's a process that they can be comfortable in. Sally's back.
She's back.
I'm so sorry. You may have just said this, but the purpose doesn't have to be a unifying single purpose across absolutely everything everybody's doing. It can be all discrete purpose that is easy to gather people around.
Yes.
Yeah, and that's that point, isn't it? The people gather, and she's gone again. I can hear a horn in the background. I just hope she hasn't been run over. That's my prayer for
I can still hear you.
You haven't been run over, have you? I could just hear a horn.
No, I don't think we're getting much joy.
Can you hear me, Richard?
Yeah, we can hear you better than your picture. So you might as well keep speaking.
I'll keep listening in. I missed probably some of the questions.
I'll There was one, I'll ask you another one from Georgie. I tried to answer it, but not in the way you would. How do other people and organisations in the NHS learn to act just like you? It's so refreshing.
I suppose looking at what each other are doing and working out whether it would work, but I wouldn't want anybody to think there's a single way of doing anything, because what Dorset does might not be right for anywhere else. Right. But I think it's just about getting like-minded people into a room, real or metaphorical, and giving people permission to try some new ideas, rather than thinking absolutely everything has to be a success and engineering it in advance. So some of the things we do won't be successful. They'll just be things we try, and then we learn, and then we move on and try the next thing.
Thank you. And just to mirror what we've got here, there's a question here about resilience. It says you talked about, this is from Amy, you talked about people fighting resilience during a pandemic when times are tough, but how do we keep that energy going during quieter times when actually we still need to implement change just as fast?
Yeah, I think it is really difficult. I just arrived for a meeting earlier with my boss and peers, and we were talking about unwarranted optimism. So we feel very optimistic about that, and you need to spread that to other people, even when maybe it isn't real. You have to keep people's spirits up.
Yeah,
because it is hard for people to value people and give them a sense of optimism, and sometimes you get that from trying something new. So I think the project I was talking about that we call Think Big, a bit confusing, is also Think Big, but our Think Big has given people a sense of optimism, just participating in the planning and the talking about it, and that gives people resilience to keep going. But it is hard, and I think there is a limit to how resilient people can be and how long people can work at the pace that they're working at.
Yeah.
Yeah, well, Sally, thanks a lot for that. We seem to have lost your picture there, but your sentiment was clearly articulated there. So thank you very much for that, Sally.
We're out of time, Sally. That's our other downside here. So rather than make you hang on any further in that car park, I'm going to say thank you on behalf of everyone for your time, your contribution. It's been wonderful, and your resilience in hanging on in there with a poor reception.
Yeah, and creativity.
It's my bad tech skills, Richard, more than anything. And thank you for having me.
It's a pleasure, Sally. Look after yourself. Thanks very much.
Sally.
Cheers.
Bye.
Bye, everybody.
Bye-bye.
And that's Sally. She's off.
Yeah, indeed so.
Thanks, Douglas.
Thank you very much. Have a great day.
Have a great weekend, all. All the best. Thanks very much. We come into these things, don't we, thinking we might have some warm-up questions, right? And we were going to do some warm-up questions, and Sally just went. She just drove on at 60, 70, 80 miles an hour and didn't stop. And I think if we were here for another hour, she'd have still been talking about what you could do and how you could do it.
Exactly. She was magic, and I like that energy. Yeah. And the fact that the energy is targeted at some very clear interventions to deliver better care, is superb. All too often we hear the other side of the coin, where people are disillusioned with the lack of progress. But she's definitely taken the compelling event, which is the COVID, and running with it. She goes, right, it's there. We can use that to propel our services forward. So I think,
and your point about the importance of resilience, like you can see that she's wrestling with being knocked back, challenged, but she believes, and actually she was ironic, wasn't she? She was talking about her role is to enable others, to make them more confident, and yet she then referenced her boss behind her, making her more confident in that she could go out and take risks.
Yeah.
So it's working all the way through the chain, that at each level people are going, no, go on, take a risk.
Yeah.
And people aren't getting isolated in that way. And if you're not isolated, you've got a chance, haven't you? You keep going, you keep pushing, you keep challenging those boundaries that come up and go, no, we can do this. And that component of leadership, it's not about noisy leadership, it's not about heroic leading, it's just about being there, giving people the confidence that they can make stuff happen.
Yeah,
Absolutely fascinating.
It's just a rolling narrative. It's just a story that comes from, you can see the hero's arc being played out, you know, for all the characters. They're on this journey to bring about change. They've got these barriers. They have support where it's required to help them continue on the journey. So as one project finishes, another one starts, you know. So that is a philosophy that needs to be embraced by a lot of trusts to enable Think Big, Act Now, because to think big needs first and foremost to be brave. We as human beings, and I'm going to digress very quickly, but as a mental health professional, I'll tell you, if you tell somebody to think really big, the biggest, wildest, most outlandish thoughts, and you get a stopwatch, you can count the seconds before the negative thoughts come in.
Yeah.
You can just count. For me, it's like 2-3 seconds, but I know they're coming, so I brace myself for it. So it's like, oh, there's a negative thought again. But to people who are not in that field, being able to maintain that enthusiasm when you've got a big idea, a big project that you want to get uplifted, is so important that you have the support around you that are able to say to you, it's okay if you fail.
Yeah. Just
keep on going, because it's about your intention now. And we've gone from tangible things in business cases, as Sally was alluded to non-tangible things, non-quantifiable things, more faith-based things.
Yeah,
So
faith-based is a good description.
Yeah.
I've lived my life in leadership terms under 3 C's. So I talk about clarity of what we've got to achieve, the commitment to make it happen, and then the capability to deliver on it. But she actually almost added a 4th one, which is about the confidence, giving people the confidence to go out and do it. And that's your faith-based. No, I believe I can and I will. Just watch me go for it. She was absolutely fascinating on that.
Absolutely. I really enjoyed it, and I think we need to get her back. Need to get her back here, and
just let her loose for another half an hour, 40 minutes, hour.
Yeah, she's good. That is the energy that we need in the NHS, and provided. And the last thing for me, last take home for me, which is superb. I spent most of my younger years in London Underground and hearing mind the gap, mind the gap, mind the gap.
Yep.
She's all about reducing the gap between the NHS commissioners, service providers. She's all about reducing gaps. Okay, so which is very, very important, because those gaps normally mean people don't project their ideas forward.
Yeah.
Because they think you are so far beyond my capabilities. I'm not even going to go and address it. But by taking that gap away, you can have that human-to-human conversation, which is what she's very personable. You know, you're not talking to a procedure. She's not going to throw the statue at you.
No.
She knows it in and out. You can tell from the way she's delivering it. But she will shield her staff, her colleagues from some of that, so that they can go on and do the things that they want to do, that they need to do.
And wasn't she, in that respect, wasn't she very grounded? And you've listed the partners around her that are delivering, but also grounded, not in NHS speak, but in just practical reality, but also understanding it from the patient's perspective. You know, I don't know how many times it came up, that view from the other side it's just so valuable. It was wonderful, really refreshing.
Oh, Richard, thank you. That I enjoyed that. I'm energized. Now I've got to think about what I'm going to do with this energy.